This training will cover the basics of chart documentation for all Medi-Cal clients at Mountain Counseling. Our objectives are to talk about the basics of charting to Medi-Cal standards. Remember, a service is never complete until it is documented. As the county likes to say, if you didn't write about it, it didn't happen. Clear, concise, and timely documentation is the biggest key to successful treatment delivery, as it enables all providers to stay up to date on the client's current condition, track what methods are working and what needs to be tweaked, and provide a reliable record of what has happened so far in the event that the client situation changes. We'll also clarify the key components of documentation and billing, specifically for Mountain Counseling and Training. And finally, we'll complete some training exercises for writing a progress note and completing all the documentation within standards. Some things to know before we get into the details. Medi-Cal categorizes different services into types, which are then billed through corresponding codes. You can see those types and codes on the screen now. These service types help guide the type of intervention you provide for a client or a family and have some strict guidelines as to what type of interaction with the client qualifies as each service type. Here's the list of the types that we use here at Mountain Counseling as an outpatient clinic for children that does not prescribe or manage medication. We'll go into the particulars of each service type a bit later, but you can always look at the Scope of Practice Manual or the Billing Resource Guide for a reminder of what interventions qualify as each type. Another big idea for Medi-Cal charting is that all the information in the client's chart has to flow together. In the initial documentation, which includes assessment, in which the clinician details the client's current condition, needs, and strengths, and uses the CANS tool that documents those needs and strengths on a numerical scale, the diagnosis, and the client recovery plan, all of that initial documentation should represent roughly the same information. The treatment note should then build on those needs and strengths identified in the assessment and the client recovery plan so that all the documentation in the chart describes the same symptomology and behaviors to address. Putting that in plain English, if the client's assessment states that he is suffering from depression and the goals in the client recovery plan are related to giving him coping skills for depression, the treatment note should not be describing how our staff is helping him manage his ADHD symptoms. When new information pops up during the course of treatment, as it often will, the assessment, CANS, and diagnosis should all be updated to reflect the changes in the client situation. The client recovery plans are also updated at least every year and every 6 months for Success First clients. Finally, the treatment goals from the client recovery plan are listed at the top of every progress note in our electronic health record CliniTrack so that we can ensure that our interventions and services are always provided with those same goals in mind. The other reason we include the treatment goals from the client recovery plan on the progress notes is to ensure that we followed the correct order in our service delivery. The Medi-Cal model is firmly based on a pattern of assess, plan, treat, meaning first you assess the client, then you plan out what the treatment will look like, and then you actually provide the intervention services like therapy or rehab. To keep this model accurate, Medi-Cal will only allow the service types of assessment and plan development to be billed before the client recovery plan is signed by the client and all providers that are assigned to their case. Any billings other than assessment and plan development will be disallowed if they are found to be dated before the signature date on the client recovery plan. The only exception to this is crisis intervention, as obviously a crisis can't be planned for after a CRP is signed. However, crisis intervention should only be billed in the rarest of cases. Definitely talk to your supervisor if you think you're facing a crisis intervention situation. In order to write the client plan, Medi-Cal allows providers to use the category Plan Development to bill for their time. But in order to truly qualify for this service category, a plan development service must mention 3 things: that the provider actually changed the client recovery plan, either adding a new service type or a modality, changing a goal, something like that the writer is qualified to provide a mental health service, and that the client recovery plan includes at least one mental health service, rather than just case management services. The last thing the client recovery plan needs to show is that the goals on them were created with the client's consent and collaboration. As we work with kids, this collaboration can also include the client's parents. However, the client always needs to sign the treatment plan as proof that the client was consulted and agreed with the goals of treatment. If the client refuses to sign, the client's parents may sign for them if the client is under 12, but documentation must be made in the progress notes. If you encounter a situation where the client refuses to sign the treatment plan, please consult with your supervisor to make sure that we document this correctly. When writing a client recovery plan, you'll utilize the Target Behaviors and Objectives menu on CliniTrack. This menu helps you build behavioral and measurable goals that have a numeric baseline and a numeric ideal measurement that the client is trying to reach. Our goals also need to include sustainability, as in how long does the client need to continue this activity to ensure that they have ingrained it as a habit, as well as how we will gather information about this goal. So goals should look something like this. Reduce clients' anxiety attacks evidenced by shortness of breath, racing thoughts, and rapid heart rate from 4 times per day to 0 times per day for 3 months as measured by collateral and self-report, and not just be as simple as reduce the client's feeling of anxiety. This is so that it's easier to know when we've achieved the goal and there's more objective measurement so that we can track our progress towards that goal rather than just seeing how the client feels day by day. The client recovery plan will note both the specific service that we plan to provide to that family, as well as the number of times per week or month that we expect to provide that service. For example, most clients receive weekly therapy, so individual therapy would be listed on the CRP with a frequency of 1 time per week. The clinician might also decide that this client would benefit from family therapy, so that would be another service modality listed on the CRP. But that modality might be noted as 1 time every 2 weeks if the clinician does not see the need for the client to have family therapy every week. In every case, note the addition of PRN. This is a convention that means as needed, allowing us to provide more than the expected amount of a service if the client happens to need it that week. That way, we can write the plan as we expect the client to utilize services, but be flexible if the client experiences a crisis or needs additional services a particular week. SATS clients will likely just have individual therapy and collateral on their CRP, unless the clinician sees a need to add family therapy, rehab, or linkage in consultation. CIS clients most often have individual therapy, collateral, and rehab. Some may also have ICC, and Success First clients might have all the services listed on their CRP if it's a sufficiently complex or high-need case. Now let's look at the specific of each service type. Starting with assessment, this service type is used in the initial intake for a client to assess their needs and strengths, gather the information needed to assign the appropriate diagnosis, and determine the client's mental status. An assessment service might also include assessment of the need for a safety plan, if the client is high risk, or assessment of the client's current resources and safety in their home environment, especially for clients in the program Success First or CIS. The clinical assessment must be redone at least annually and can be updated whenever the clinician learns new information that might change the client's needs or strengths or their diagnosis. Only clinicians can bill assessment, as this service type requires the appropriate educational background to evaluate the client's mental health and give a diagnosis. Moving on to the planning stage, the service type plan development is used to bill for time spent creating a client recovery plan. At least one billing for plan development must include client involvement, and the caregiver if applicable, but it's okay to bill plan development anytime a written change is made to the client recovery plan, whether the client is present or not. For example, if the clinician decides to add the modality of rehab to the client recovery plan, 2 months into the client's treatment, they would bill plan development for the amount of time taken in writing up the focus and purpose of that service and adding it to the client's recovery plan in CliniTrack. Again, plan development should only be billed by the clinician assigned to the client's case. Individual therapy is the service that remains most constant across all our programs. This service, as its name suggests, should be billed anytime a clinician provides therapy for a client, giving the client tools to manage their symptoms, exploring the client's thoughts, feelings, and behaviors as they relate to their diagnosis, and generally improving functional impairments that the client's diagnosis cause. This can be therapy with the client and the clinician one-on-one, or therapy that includes some members of the client's family. The individual portion of the name refers to the fact that only one client is present, regardless of how many natural supports are in the room. However, individual therapy and individual family therapy must be added as separate modalities on the client recovery plan if both will be provided to the client, as not all clients will receive family therapy depending on their family situation, diagnosis, or symptoms. Therapy can be provided over the phone, but not by video or text. This service, of course, should only be billed by clinicians who have the appropriate education to provide therapy. Similar in intent to individual therapy, but very different in method, rehabilitation or rehab ADL services primarily focus on helping clients develop the skills needed to manage their symptoms, complete necessary daily living tasks such as personal hygiene, academic achievement, and general self-care tasks, especially for those transitional age youth, that is, teens 15 and above, who are getting ready to make the jump from living with their family to potentially living on their own or in a college environment. This could also include some work done with the client's parents or caregivers, as long as it relates to helping the client and family build the skills they need to be successful, despite any impairments that their diagnosis might cause. While a clinician can bill rehab, rehab services should primarily be billed by family specialists so that clinicians can focus on therapy. So if both therapy and rehab focus on helping the client be successful at managing around the symptoms of their diagnosis and utilizing their strengths, what's the difference? It has to do with how the provider approaches the changes the client needs to make. Therapy involves changes to the client's basic personality and patterns of thinking. Therapy could involve teaching the client to think differently about situations, respond differently to certain thoughts or emotions, or learn where a particular thought, feeling, or behavior is coming from. Rehab, on the other hand, focuses only on behaviors. A rehab service gives the client a new skill to use, such as communicating better, organizing their schoolwork so that they have fewer missing assignments, or learning how to use stress management tools or anger management tools when those feelings come up. Put another way, rehab is more reactive, while therapy is proactive. For a client who experiences test anxiety, a rehab service might teach them how to recognize that they're getting stressed and use a stress management tool to calm back down so that they can take the test successfully. Therapy for that client would focus on why the client experiences anxiety about the test and ways to stop that anxiety before it interferes with their test at all. Overall, therapy is more broad than rehab, which focuses solely on skills for the client. While it's true that some component of rehab could be teaching the client about their diagnosis or the specific symptoms that they're experiencing, the majority of the documentation for a rehab service should be focused on the skills that the client is gaining. Further along the skill continuum, intensive home-based services unite similar concepts as a rehab service with therapeutic behavioral services, or TBS. As the name suggests, this service is provided solely within the home and is usually appropriate only for clients in the more intensive services, CIS and Success First. IHBS is useful for cases where significant behavior change will be needed for the client and potentially multiple members of the client's family in order to keep the client safely in the home. It might also be used to train natural supports in helping the client manage their symptoms in particularly severe cases. IHBS will primarily be provided by a family specialist, though a clinician might also provide the service in certain cases. Intensive care coordination is another service that is usually provided to the more intensive cases. ICC is appropriate for any client who is involved in multiple systems of care. That is, they're receiving mental health services while they have an open CFS case, an open probation case, or an IEP 504 plan at school. The main purpose of ICC is to ensure that all systems of care are helping the client toward the same goals, and providing a main point of contact for the family so that they're not trying to coordinate with the social worker, probation officer, school officials, and all those other systems of care separately. ICC services might also evaluate the client's treatment so far and suggest changes to the current plan so that the client will experience greater success. Examples of an ICC service are broad, but the fundamental hallmark of an ICC service is that it is coordination with another agency or individual who is significantly involved in the client's long-term care. This could be a social worker, probation officer, teacher, school administrator, psychiatrist, or another mental health professional from another agency. For SATS and CIS clients who need ICC services, the clinician will provide that. For Success First clients, the assigned ICC coordinator will manage those tasks. Another important Medi-Cal service type, especially for children and adolescents, is collateral. This service type is one of the only services that can take place whether the client is present or not. The main purpose is to teach significant people in the client's life how to help the client manage their symptoms, learn about their diagnosis, and generally meet their goals despite any obstacles caused by their diagnosis or current life situation. For the grand majority of our clients, collateral services will focus on the parents or guardians, teaching them to tailor their parenting style to the client's particular needs and strengths while keeping the goals, culture, and values of the family in mind. An important distinction: collateral services cannot be used to provide individual therapy or marriage counseling to the client's parents, as the focus of the service needs to be on the client's needs and strengths, not the parents'. Collateral services might also occur when the clinician or family specialist needs more information from the guardians regarding the client's current progress towards their goals, especially if it is a goal that's difficult for the client to accurately self-report. Collaterals can also be used for the client's teachers or school staff who have significant interaction with the client to help them understand the client's symptoms and diagnosis while teaching the school staff about necessary changes or accommodations that should be made to allow the client to be successful in the most appropriate school environment, whether that's a mainstream classroom or a specialized education classroom. The last service we will talk about is linkage and consultation. This service should be used anytime a client needs to be linked to an appropriate outside resource that will help them reach their mental health goals. It allows our staff to do more than simply provide a contact number, but we can also accompany a client to a specific resource center or follow up on a referral to ensure that that resource is working out well. This might be something like assisting a client in applying for a job, assisting a client in applying for Social Security benefits, helping a family connect with a food bank or appropriate housing, or any other resource that will significantly contribute to improving the client's quality of life as they manage their mental health diagnosis. The focus of an LNC service should be to connect that client to the resource, as well as to teach them how to utilize that resource long term, so that the client can continue using similar resources even when formal mental health care is ended. For most cases, the family specialist will provide LNC services when the clinician identifies a particular resource that a client needs. In Success First, the assigned parent partner will assist in identifying resource needs and provide any necessary LNC. So now that you have more detail on all the services, let's review which person on the team provides which services. Starting with the clinician, this team member is responsible for assessment, plan development, therapy, and collateral services with the client's parents or significant others in the client's life. The clinician assigned to the case is also responsible for crisis intervention if a determination must be made about the client's safety or the safety of others that would require the client to be hospitalized. Crisis intervention is very rare, however, as we are an outpatient clinic. Any situation that approaches crisis intervention should be reported and discussed with the clinic supervisor as quickly as possible to ensure that appropriate services are provided to a client who may be in danger. The ICC coordinator on the case will primarily bill intensive care coordination, especially in the child and family team meetings that include other providers and agencies. For those clients in SATS and CIS who need ICC, the clinician will provide those services. If the client is in Success First, the ICC coordinator will provide ICC, as well as any collateral or LNC services necessary to ensure that the client's treatment is progressing appropriately. The family specialist mainly bills rehab for any cases that are assigned a family specialist. In high-need cases, the family specialist might also provide IHBS. Like the ICC coordinator, the family specialist can also provide any collateral and LNC services needed to help the client learn the skills they need and achieve their particular behavioral goals. Finally, the parent partner, only assigned to Success First cases, is responsible for billing LNC services for Success First clients and ensuring that they can access all necessary resources to stay safely in their home and community. The parent partner will also provide support to the client's parents in a non-billable capacity and research resources more generally. So once you've provided a service, let's talk about documentation. The documentation required for a service is called a progress note or an ID note. These can also be called a chart note or a pink note, as they were printed on pink paper before the adoption of our electronic health record. Most often we call them progress notes. In every progress note, the writer must include a description of how the client is currently doing. Are they well groomed? What's their mood? How are they doing today? We also need to talk about their goals from the client recovery plan and how they're progressing. Medi-Cal doesn't require that we address medical necessity in every note, but it's best to always include it so that any progress note that another provider reads gives them some indication of where the client is in treatment. The next thing the note needs to include is the provider interventions, or what did the provider do to help the client reach their goals, and then the client's responses, both to specific interactions and to the service overall. In order to make sure that we get all of these parts in our note, we use a structured note. CliniTrack will automatically impose this structure on any billable note with a box for all of the categories. It's called a SMRF note, which stands for Status, Milestone, Intervention, Response, and Follow-up. So let's take a closer look at what each of these structured headings means. The first box in the note is the reason for contact. Here's where you explain why you met with a client, and if you met somewhere other than the office, why that was necessary. There has to be a medically necessary reason that we met with a client at another location. So it's more than this writer met with the client because the client has a weekly standing appointment. If there's travel time, Medi-Cal needs to know why it was necessary to reimburse that time. So explaining that the client often has difficulty coming to the office due to transportation needs, or that the provider needed to see the client at home in order to observe the client in a natural, comfortable environment is a much better thing to put in that place. If this was a rehab service, you might explain why you needed to go to a certain community location to help the client work on talking to peers in social settings, or complete a task related to adult transition by helping the client apply for jobs. Then in the status, the writer explains how the client is currently doing, both their general appearance and their general mood or status. In the milestone section, you can see that the writer talks more generally about the client's goals and the client's progress towards these goals. This category is often broad, as here in this example, the writer just stated that the client is working on social interaction. But the writer does make it more specific to this particular client, with the later examples that the client is often withdrawn and has conflicts with mother. It's okay to summarize the goals as long as it's clear how that goal applies to this client individually. Medi-Cal needs to see that each client is receiving individualized care. Then in the intervention section, the writer uses active words to show what the writer did to help the client reach that goal. This section should be the longest of the note, as this is the section that justifies the amount of time that the service took. There's a tricky balance here of explaining enough so that another provider or an auditor knows what happened, but without including the detail that distracts from the service or spends too much time quoting the client and not enough time on what the writer did and how the client responded. You want to capture the process of the service without including all the back and forth details. It's best to focus on the higher level of how you provided that specific service type and the effect it had on the client, rather than the nitty-gritty of everything that happened while you were with the client. A good idea while you're getting used to this format is to copy and paste descriptive sentences from the service type in the billing resource guide and then personalize them to the particular service you gave that day. Again, it's okay to summarize here as long as the big ideas of how the service individually applied to the client are apparent. Then in response, record the overall response that the client or anyone else involved in the service had. Were they generally engaged? Did they begin the service angry and uncooperative but become more invested as the service continued? Were they withdrawn throughout the service? Give a 1 or 2 sentence high-level description of their overall response to the service. This is also where you might note if a particular intervention worked especially well for the client, or if a particular tool was not helpful for the client and shouldn't be tried again. Finally, the follow-up section records when you next plan to see this client and how you will follow up on the particular skills or subject from this progress note. It's important to include a specific date here, as well as a general statement of what things from this service will carry over and any items that you'll need to check in on. So to look at the documentation process as a whole, the client starts at intake with the consent, notice of privacy practices, and client resource evaluation completed within the client's first 2 visits. Normally, administrative staff take care of this aspect, but direct service staff may interact with these intake forms if a client changes programs. Then the service pattern follows with the assess, plan, treat model. In the assessment phase, the clinic supervisor or clinician assigned to the case completes the clinical assessment, the care necessity form, and the diagnosis sheet. This is all recorded on the episode summary to open the case in Simon. The time for the assessment is also recorded and billed with a progress note and a CDI. In the planning phase, the clinician assigned to the case completes the client recovery plan with client and caregiver collaboration. The time spent planning and writing the treatment plan is also recorded and billed with a progress note and a CDI. Then the client enters the treatment stage. Each service or interaction with the client is recorded with a progress note and then billed with a CDI in CliniTrack. In order to keep documentation current and as useful as possible for others who might be trying to follow the case, progress notes should be written in CliniTrack within 24 hours of the service provided. From there, your clinic supervisor will review the note and return any needed edits or comments within 24 hours. And finally, when the client has reached his or her goals and no more treatment is necessary, the clinician assigned to the case completes a discharge summary, which allows the administrative staff to fill out the episode close summary and close the episode in Simon. The discharge summary would also be completed for clients who dropped out of treatment due to loss of contact or who requested that service be ended early. In those cases, administrative staff will also send a written notice that the case is being closed.